Hello, this is Dr. Grande. Today's question is, what is major depressive disorder? So with major depressive disorder, there are symptom criteria as well as some other criteria. And for somebody to receive a diagnosis of major depressive disorder, or MDD, they would have to have at least one major depressive episode. It's not unusual for individuals with major depressive disorder to have had multiple major depressive episodes through the course of their lifetime. When we look at the definition for major depressive disorder in the DSM, the Diagnostic and Statistical Manual, we see a number of symptom criteria in Section A. 5 or more of these symptom criteria need to be met in the last 2 weeks. However, with the first 2 symptom criteria, one of those 2 symptom criteria must be present. The first symptom criterion is depressed mood, and this would be most of the day, nearly every day. The second is markedly diminished interest or pleasure in all or almost all activities. And again, this is most of the day, nearly every day. So one of those 2 symptom criteria must be met. Now looking at the other symptom criteria, the first one is a weight gain or weight loss. So either one of those can occur. Then we have too much or too little sleep. The way we usually see this with major depressive disorder is someone can sleep initially, they can get to sleep, but then they wake up and have difficulty returning to sleep, or they can't get back to sleep at all. This is referred to as middle insomnia. The next symptom criterion is psychomotor agitation or retardation nearly every day. Now this is a relatively uncommon symptom in major depressive disorder. However, it is associated with a more severe presentation. Also with this symptom criterion, the psychomotor agitation or retardation must be observable. This wouldn't be simply a subjective self-report. This would be something that a mental health clinician could observe. The next symptom is fatigue or loss of energy nearly every day. Now this is a fairly common symptom we see in major depressive disorder. As a matter of fact, this is one of the more likely symptoms that would be the initial complaint when somebody comes in to be assessed for the symptoms. So oftentimes, as mental health clinicians, we find out about this complaint first, and later on we find out about depressed mood or diminished interest and pleasure in activities. With the next symptom, we have feelings of worthlessness or excessive or inappropriate guilt. And again, this is nearly every day. With this particular symptom criterion, sometimes we see that these feelings or this inappropriate guilt rise to the level of being delusional. So with some presentations of major depressive disorder, we do see delusions or hallucinations, psychotic symptoms. The next symptom criterion is trouble concentrating. Again, this is nearly every day. And the last symptom criterion is recurrent thoughts of death. This also includes suicidal ideation, a suicide attempt, or a plan to commit suicide. So those are the symptom criteria for major depressive disorder. There are 4 other criteria. There needs to be clinically significant distress. The disturbance can't be better explained through substance use or medical condition, or from schizophrenia, schizoaffective disorder, and some other related psychotic disorders. And there can never have been a manic episode in the individual's history. If there's a major depressive episode and a manic episode in the history of an individual being assessed, bipolar disorder would be considered rather than major depressive disorder. Now there are a number of specifiers with major depressive disorder. We could think of major depressive disorder first as being divided in 2 categories, recurrent and non-recurrent, and I'll talk about that more in a moment. Also there's a severity specifier, mild, moderate, severe, and there's a with psychotic symptoms specifier. So those would be delusions or hallucinations. We also see partial and full remission available as specifiers and unspecified. There are also a number of other specifiers like atypical features, mixed features, anxious distress, and all those have particular criteria associated with them. The 12-month prevalence of major depressive disorder in the United States is around 7%, and females are more likely to be diagnosed with this disorder than males, about 1.5 to 3 times more likely. Interestingly, however, the course and the treatment response for major depressive disorder is about the same for females and males. With major depressive disorder, it's important to understand the concepts of recovery, relapse, and recurrence. We see these a lot in the literature, and unfortunately, there's no one set of definitions for these three terms. They're used in different ways depending on the article. Recovery usually means that an individual has had 2 months where they don't meet the full criteria for major depressive disorder. And relapse usually means that it's been less than 2 months. So really with the relapse, there's no new major depressive episode. It would be considered part of the same major depressive episode because there needs to be 2 months in between to establish a separate episode. So somebody has a major depressive episode and the symptoms appear to go away or they no longer qualify for the full criteria, and then the symptoms return. That would be a relapse, again within 2 months. Now a recurrence means a new major depressive episode has occurred. So there was at least a 2-month period where the full criteria were not met and the symptoms started again. So going back to recovery, major depressive disorder has a variable pattern. Around 40% of individuals who have a major depressive disorder will start to recover in about 3 months. There are factors that can lower this recovery rate. For example, the presence of psychotic features, increased severity. Again, there's mild, moderate, and severe, 3 levels of severity with major depressive disorder. Prominent anxiety being featured, as well as the presence of a personality disorder. Other items from the course of major depressive disorder would include that a lot of individuals who have bipolar disorder would first have a major depressive episode. So if somebody has a major depressive episode, that could go on just to be major depression, and most of the time it would, but sometimes that's an indication that bipolar disorder is present. Of course, there would need to be a manic episode to establish that diagnosis. So some of the individuals who are initially assessed with major depressive disorder will actually go on to develop bipolar disorder. We see the same thing with schizophrenia. If an individual has major depressive disorder with psychotic symptoms, sometimes that individual can go on to receive a diagnosis of schizophrenia. Now in terms of recurrence, and this is when a new major depressive episode occurs. So there's one major depressive episode, a 2-month period where the full criteria are not met, and then another major depressive episode. In terms of recurrence, we see that 50% of individuals who have one major depressive episode will develop at least one more major depressive episode in their lifetime. Around 80% of people who have experienced 2 major depressive episodes will go on to have at least one more. So in terms of recurrence and a second major depressive episode, we usually see that within 5 years of the first major depressive episode. Not all the time, but usually. So over the years that I've treated major depressive disorder, I've noticed a few different characteristics the disorder has, a few themes have emerged. I want to touch on just a few of these. One is that major depressive disorder is particularly isolating. If you look at the symptom criteria, of course it's easy to see how an individual with this disorder would become isolated. And one of the elements I've noticed with this isolation is that family support is an important part for many individuals with or without major depressive disorder. And when the depressive symptoms are active, sometimes individuals from the family will distance themselves from an individual with major depressive disorder. I find this to be unfortunate because a lot of times this leads to an exacerbation of the depressive symptoms. Another element I've noticed is that oftentimes with these major depressive episodes, there's some sort of stressor that can be clearly identified. However, much of the time, there's really no apparent reason. A person can seem like they have everything going for them, there's no real major stressors, and yet the symptoms of depression come on. So they're unexplained and unexpected. The last item I want to point out here with major depressive disorder is the comorbidity with substance use disorder. I think what happens some of the time is the symptoms of major depressive disorder are so severe and so disruptive that individuals turn to substances to try to get some relief. And then unfortunately, there's major depressive disorder and substance use disorder together. Sometimes, however, substance use disorder could have started first, and then because of the stressor of using substances, we see major depressive disorder. It's not clear how often each of these happen in terms of major depressive disorder coming first or substance use disorder coming first, but we do see both of these types of presentations when treating major depressive disorder. There are a number of relatively effective treatments available for major depressive disorder, including individual psychotherapy, group psychotherapy, and medications. When we look at the studies of effectiveness of these treatments, we find that the highest level of effectiveness seems to be when talk therapies and medication are used together. I hope you found this description of major depressive disorder to be interesting. Thanks for watching.